Dr. Mohammad Rahman Patwari, Dr. Tarun Madan, Dr. Kamal Sharma, Dr. Jai Shah, and Dr. Hari Om Tyagi. Over to the cath lab.
Hello, can you guys hear me?
Perfect sound, Tejas.
Yeah, good morning, everybody. And Rajiv, uh, I hope everybody had enough rest last night. It is too exhaustive for everybody, I know. But again, we are going to, we will try our best to make it interesting. Here with me is Sanjay, as usual, and our on-site commentators we have are for imaging, we have again Professor Akasaka and Professor Malcolm Bell from Mayo Clinic, and our new friend Professor Mirjamol Zufarov from Tashkent, Uzbekistan. So please come over on this side. Acha, yeah, please come. So this is the case history. Now, can you uh, give the case history to the
Good, good,
audience?
good morning, everyone.
Yes.
Our first case of today is a 62-year-old female who is a known case of diabetes and hypertension, presented to us with a chief complaints of chest pain. Her 2D echo showed normal LV function, LVEF 55%. Coronary angiogram showed CAD TVD, heavily calcified lesions. Her syntax score is 15. Our plan is to do multivessel PCI using OCT guidance and IVL.
The right, these are the left views. The lesions are discrete but extremely heavily calcified. You can go to the next, please. Rajiv and Khaled and all other, panelists, are you able to see the calcium there?
Yeah, these are beautiful images, Tejas. We can see them well and we can hear you well. Focal,
Yes.
heavily calcified.
Focal lesions heavily, and this is the right, which probably has the maximum calcium load, and it has two lesions, one at the bifurcation also, and I will be embarking upon the right first. So give me JR guide, and as usual, this is our default technique for any intervention. Combo technique, 5 French multi-purpose 125 centimeter and 6 French JR launcher. And again, this is the baby J wire from Terumo.
So, Tejas, a question here just on the choice of revascularization. So, focal disease, low syntax, but she is diabetic. Did you think about bypass surgery or was that not even an option for you?
I thought that nowadays, with available imaging, Rajiv, bypass is a good option. But she is quite obese, and in South Asian, particularly women, particularly in and around this region, most of them are pure vegetarian, and there is always a problem of healing and calcium deficiency and all those issues. So we always give them a chance of cath lab intervention to start with, and with imaging, I think we are able to achieve a reasonably good minimal stent area, and in that case, the event rate also is quite substantially under control. So we give this, and we are used to. And now you see, Rajiv, again, let us presume. What do you think about the proximal? Go to aleocranial proximal lesion. How will it look in OCT? And how will it look in IVUS? Let us go retrograde.
video
Okay. Now, go to aleo. Any idea? Give one cc dilziam. She has normal.
we are given.
Sure
we are,
looks heavily calcified. It looks like you can see nodular protrusion.
Very true. This is a big calcific nodule, very big calcific nodule there. And in the distal area also, I think it is a heavy calcium and maybe a nodule. Now, what could be the strategy about that bifurcation? Will you go for a full-fledged bifurcation strategy or provisional T or what?
We're going to ask the panelists here to comment here.
Yeah. Come, Malcolm. Malcolm, please. Yeah. Yeah. Wait. Mic on. Mic on, please. Yeah.
Sir,
Gopal.
please.
Please, Gopal. Yes.
Close up
Yeah.
the
About distal, it seems
Close.
to do provisional and open the another orifice of the right that artery will be okay. One stent the technique it will be enough for distal part.
What are the if we go for provisional T again? If you whether you will like to put one wire or two wires.
Yeah, of course, two wire.
I tell you, two wire. You know, it's a very good traditional thinking, perfect. But in this case, even if I put single wire, PLV will not occlude 99.9% because you have something in buffer in between also. That is a small branch. So whenever we see such a small branch, something in between, that becomes protective to the larger branch. Malcolm, any comment on that?
Well, first of all, I'd like to make a comment. But the question came up about surgery and diabetes, and you said that she was obese. From where I'm standing here, this is not the same obesity that we see in the United States.
Yeah.
So I just want to make that point.
Yeah, but for South Asian population, the BMI index, for obesity is not, like 28.5. It is 25.5 or 26.
This is normal size. This is considered to be normal. But anyway, I would agree. And I guess the only other question, I mean, it's a big posterolateral branch. The PDA is very, very big.
Yes.
So I don't think, but I agree with you, the chance of losing the posterolateral is very, very small. And the question that I would have, though, is a big vessel, and would you go 6 French or 7 French to give you the option if you do have to go to a 2-stent strategy? Because that may change once you've pre-dilated.
Let me tell you, if you are using one 3.5 and one 3 millimeter and one 2.5 or two 2.5 millimeter stents, 6 French is perfectly all right. So if they are bigger stents, maybe 3.5, a couple of 3.5 or 4 or 3.5, no, it will not work that way.
Although these do look like big vessels, that's why I was thinking maybe bigger stents.
Let us see.
Good morning, Dr. Tejas sir, Dr. Kamal Sharma.
Yeah, Kamal, how are you?
I'm good, sir. Congratulations for Padma.
Thank you.
Again, it's in vogue now to actually stage procedures. Are you intending to do all the vessels in one sitting?
No, that's a good question. I may or may not, depending on how long I take to give the result, because I will be concerned about the contrast load in this case. She is a diabetic female and diabetic duration is pretty long. So I will not take chance. And you know that even the upper limit of serum creatinine in most of the lab is 1.4 or 1.3. 1.2 cannot be taken with a pinch of salt in view of creatinine clearance part.
Completely agree, sir. And again, as Professor Malcolm was mentioning, BMI of 23 would actually amount to grade 1 obesity in Asians, but EGFR for 1.2 creatinine for an Asian Indian versus for a Caucasian for the same BMI weight may again give you a different EGFR values depending on which formula we are looking at.
So first and foremost is LAO, go to LAO. I will try to dilate this with non-compliant balloon and then we can see how the things work. So for the proximal and distal, Sanjay, should we do graded dilatation? Because proximal we will have to take at least 3 or 3.5. Yes. Maybe 3 at a high pressure we can go. Distal also, I think 3 should be okay. So let us take first 3 by 15 NC track neo. We'll try.
Can I just come back to
OCT.
the discussion about the
After dilatation. Sorry, for that question, whether you will like to run the OCT at least for the proximal lesion prior to dilatation, or you want to dilate? Because OCT image, I am not sure. What do you think?
Dilatation distal part. Start here.
Professor, what do you think? We can see?
We can see, I
Okay,
think, yeah.
let's do that then. Now, OCT.
just as you're setting that up, I just want to go back to that question about the diabetes and the kidney issue that you just brought up.
Yes.
So as you probably know, there's a lot of controversy, certainly at our institution, about whether contrast-induced nephropathy, it really exists.
That's
and,
right.
and we know that with a radial approach, deterioration in kidney function is really uncommon.
Okay.
So I just want to ask, how often do you see acute kidney injury in your patients undergoing PCI? And let's just stay with the diabetic patients.
It is not uncommon. At least long-standing diabetic who have extremely uncontrolled sugar levels, and if the creatinine is 1.3, and if somehow by any means you are giving a higher contrast load, even if it is VC-PAC, which has the osmolality almost near to the blood osmolality, on third or fourth day we see one bump of creatinine, and then by and large it becomes normal. But we always observe, and we always involve our nephrologist, and our nephrologist is also insistent about it. Any comment from the panel?
I try to change my mind, right? Proximal should be okay, but the distal we
No,
need
we-
a pre-dilatation.
Yeah,
right,
but we are seeing proximal
Okay,
first.
okay.
Yeah, let us see.
With regards to the contrast nephropathy, yes, your word is very well taken. I think except hydration, we know from literature nothing except hydration works. So those fancy and acetylcysteine and all that stuff probably is not that an important strategy. Contrast volume, again, as Professor Malcolm was saying, remains questionable, but what matters most is probably perioperative hydration.
Rajiv, see this, there is a lot of grit going through the lesion. I feel tactile feeling. Yeah, it just jumped in.
Good morning, sir. Tarun here from the panel.
Yeah, Tarun, how are you, my friend?
Great, sir. There is a lot of mismatch between the distal caliber of the RCA and the ostium of PD. So is there a possibility we can do a dilatation with a non-compliant balloon and treat it with a drug-coated balloon?
Drug-coated balloon, somehow it is a good technology, but it doesn't enter my head as of now, because I personally feel that you are painting the wall of the artery with a drug. And that too for a very transient time period. There are some data available, I know that. But I don't know, I mean, what is the opinion from the, I may be completely wrong. But somehow this is a preconceived notion I have, and that is the reason drug-eluting balloon is still not there in my lab. What is your comment, Malcolm?
Nothing yet, because I have no experience, because we don't have them available.
Good morning, Tejas. It's Khalid Ziada.
Khalid.
Nice case. I tend to agree with you actually about the drug-coated balloons. I don't know where they will fit in practice, but we need a lot more data. I don't think we have good data on complex lesions like these. So for simple things maybe, but for calcified lesions, probably after you pre-dilate, there will be a small dissection. Maybe it won't be expanded. So I think it needs a little bit more work than just painting the walls, as you said.
Yeah, and another thing, Khalid, that here I have heard quite a bit, even from the panel yesterday, that what if dissection happens, you cannot sleep and there are heartburns. But one thing I tell you, heavily calcified lesion, it is my 32 years of interventional experience. If you dilate and if the artery looks good, well open, and if there is a little bit of haziness with some dissections here and there, normally they don't recoil, because I think there is hardly any elastic tissue in that area to recoil. What is your comment?
I think so, because just if you see physiology, this after calcification, it can not come down. So I'm also, when it's calcified, we can be sure there will be not recoil.
Rajiv, we are doing again the same thing, and now Sanjay will show, because you saw that there is lot of grip while going in and it simply jumped in. Now we are doing OCT and see what he is doing. He is giving it very slowly to start with. And once he will see the lens moving, he will run it. Yes. And this is a beautiful image. Zero default image. Perfect.
It was a beautiful image. How much contrast did you give Sanjay there?
7 cc. Professor, now you give commentary. Relax. બાટલાની ચિંતા જ ના કરો. એ બાટલો એમનો પેલો ત્યાં આગળ એ થયો છે, બંધ કરી દો, વાંધો નથી.
Good morning, Tejas sir. This is Jay.
Hi Jay, how are you?
Fine, sir. Thank you, sir. Sir, in this case, when we look at the angiographic picture, would you like to consider physiology first, or because the proximal and the mid part of the RCA is almost looking like a borderline.
Jay, how much you trust? Let us be very, very, frank. Physiology has extremely good evidence base as compared to imaging, as far as the deciding the guidelines are concerned is class 1. But tell me, in your near and dear, if this type of block is there, will you be dependent, or will you bank upon the physiology or pathophysiology?
No, sir. I think I would like to go ahead with both the modalities.
Then I beg to differ. I will be trusting more the pathophysiology. Like you see TCFA and other thing, and if you have 0.90 of ISR with an extremely unstable, vulnerable lesion, will you leave it alone on medicine? It is a debatable thing, but yeah, this is what is my opinion. Yes, okay, Professor?
Okay, here is an acute marginal. You can identify here, right? Then I try to provide another branch. Can be seen, right? But another branch. There are 3 branches, right? Then yes, here might be the nodule. Big nodule. Calcium nodule, and then some elapsed, right? So calcified nodule here, right? Little bit unstable, right? Yeah, right. And very thick calcium here, from here to here, right? More than 180 degree, and this is also the calcified nodule.
This is what bothers me a lot, because there are very high chances of balloon rupture.
Yes.
Yeah, there are 2 such spikes in the same lesion.
And this is not a simple calcium, because you can identify the shadow here.
Yes.
That is a mixture of the red thrombosis, so this is a little bit unstable, right? Yeah. Then another nodular calcification. Here is a simple calcified nodule, right? And the MSA is very tight and very complex. Calcium here, and very complex lesion, right? And then back to the proximal site. Also
healed plaque, right?
And also another calcium here, right? And superficial calcium the opposite site. Very complex lesion, right? And the true proximal should be okay, but some calcium can be identified.
Yes.
Very complex.
So now, what should be the strategy? Will you dilate with, you want to see and try and dilate with the balloon? Yes, I will do that. I will at least try and see. And if either balloon ruptures or balloon does not open up, then what? Will you consider rotablation before IVL, or you will straight away go with IVL balloon? Because IVL balloon is after all a balloon, and there are chances of rupture. We have seen a couple of ruptures with IVL balloon also.
I'm just wondering, here is a very thick calcium. Simple balloon dilatation may not make
this is your study, right?
Yes.
More than 500 micron thickness. The balloon dilatation simply does not work completely.
Does not work. So if you dilate, you can identify some this dissection here and here, right? But not here, right? So And wire position is very good, so some rotablation is the best way to modify the lesion first. And after then, we can decide IVL or something.
See, I am tempted towards rotablation in this case because of one thing, because I am sure that the bifurcation lesion will do beautifully with rota to start with.
Yeah.
And that can make our life easy. It may do some superficial calcium scraping in the proximal part, but the bifurcation lesion will be cleared. 1.5 rota? Okay.
Yes.
So now
The calcified nodules, how does that influence your decision?
Yes.
rota
Simple nodular calcium is we cannot identify any
Eleocranial
shadow,
માં wire
right?
જોઈ લેવા દો.
Like this. This is nodular calcium. Recently,
It's a complex
the CRF group, this is non-elapsed, right?
1.5.
Non-elapsed calcified nodule, but we can identify like this. Lots of shadow similar to the red thrombs. Yeah, right. That might be the calcified nodule, right?
Dr. Akasaka, can we ask a question?
Yeah, I think so. Yeah, but the protrusion to the lumen side through the stent is a problem of the stenosis.
Fine cross law.
Can we ask a question, Tejas, to Dr. Akasaka? He made a passing comment on the position of the wire in relation to the protruding calcium, and I think he was suggesting that should mean the bias favors rotational atherectomy. If that was not the case, if the wire was on the other side of that protrusion, would you recommend a different rotor wire, like a rotextra support wire, or how would your strategy change based on the wire position next to calcium?
Yes, sometimes it might be very difficult, but I think in this case it's quite easy to do the rotor, but if the wire is a little bit opposite, sometimes we try to select the orbitaterectomy or pull back way or push manner, right? So try to use the wire position is very important to make an effective ablation. Right? If the wire is far from the calcium, it might be very difficult to make an ablation using any kind of ablation system.
That's a great learning point. Thank you.
I think another question here, we're talking about rotablator, right coronary artery. Are we going to be using any drug therapy here, ammonophlin? Do you ever use a pacing wire? Maybe comments from the panel.
Rota wire, floppy. Pardon? Pacing wire.
Or ammonophlin, asking ammonophlin, anything? Or
No.
So no ammonophlin, no pacing wire?
No.
So how do you avoid the bradycardias, and what's your technique?
If it bradycardia with, if we feel it is vasovagal situation in our lab, hardly we use atropine. It can be a very controversial comment. And by and large, we are taking care with adrenaline, epinephrine. Because there are two components. One is, vasodepressor component and cardio inhibitory component. We always feel that vasodepressor component predominates and adrenaline works. And if need be, it takes another 1 minute to put the pacemaker. But in our practice, Sanjay, how many times we have? Zero. As of now, we are lucky.
That's certainly our experience at Mayo. I'm not sure the last time we had to use a pacing wire. We typically might use ammonophlin, although very often you wonder whether it was really necessary or not.
Yes.
But Rajiv, maybe you can get some other opinions from the panelists there.
Yeah, good morning, Malcolm. This is Khaled. We use ammonophlin routinely for RCA roto. We, as everybody mentioned, I don't remember the last time we used the pacemaker wire, but we do use ammonophlin routinely.
Just a small comment about using adrenaline. In case you are not ready with the pacemaker and ammonophlin might take time, there is a method of giving adrenaline. You just take the adrenaline and remove everything, then again flush it with saline, and whatever small amount remains can be injected intracoronary and will have instant effect. Instead of giving IV adrenaline or intracoronary adrenaline without dilution, this type of adrenaline works immediately.
I tell you, you know, in 1993, when I was under training with my friend Alan Cribier at Rouen, France, he taught me these things. If you come across the arrested patient, and if you need 1 or 1.5 or 2 minutes, just don't do anything. Push some adrenaline inside the coronaries. The pressure will be 150, 200. Do whatever you want with VTVF, whatever, go on giving shock. And during that time, if you deploy IABP with a reasonably good pressure, many times you can keep the patient alive.
1.5.
Yeah, I think the point being made is the dosing here. So you don't really need very much epinephrine or adrenaline to go down the coronary. And so even like 10 mics, 20, 30, 40, 50 mics, that's all you need.
Yes.
You don't need to go and give 1,000 mics and have then dealing with hypertension and VT.
So we are in with a floppy wire. We have used you know, fine cross microcatheter from Terumo and 1.5 millimeter bar. And this particular technique, we learned from Dr. Samin Sharma way back in 95, and till then we have never faced the problem. And what is the rule of 5? Can you tell, Sanjay, to them?
In pint we use 5 milligram diltiazem, 500 microgram nitroglycerin and 5000 units heparin, and that is a continuous drip in the rotablator bar.
And that, flushing is done with this saline, with, you know, these 3 components, with a figure starting from 5.
So Tejas, I'll tell you something a little different.
Yeah.
I don't put anything in the roto except saline.
Okay.
Nothing at all. And I
Okay.
just give a little nitro before I start the run, and that's it.
Okay. Yeah. So this is like, you know, when you are happy with your wife, you don't need to have a girlfriend. Now we are testing. Where is the I need to.
A pint hour.
Flushing?
Flushing plus I.
Yes. Bring it little more proximal. Sanjay, you are having the brake there, right?
Yes.
Just open the brake and make it little straight.
Okay.
Young guys who are not very well versed with rota, we will go step by step, spend some time here, straight, little bit more straight.
Okay.
Now lose it. Bas, that's it. Dyna off. Let us check the speed. Set it at 1,50,000. Perfect. Right.
Okay.
Dyna on. That's it. Lovely. Now, here you always need 2 guys. A wire. Wait. No problem. I think it is PDA. No. It is an intermediate artery. Sanjay.
I am taking little back.
Little back. Let me come out and go in.
So, sir, are you planning to rotablate the PD ostium as well?
Yes, that is very important. Scout, Sanjay. This is a very, very uncoated wire, stainless steel. Law. Sanjay, by and large, this torquer does not work.
Okay,
Let me see.
So your experience of Rota Pro versus the routine Rota that we've been classically using?
This is routine. Rota Glide, I have no experience, Scout. I should have it.
You mean the button, the new rotor?
I think, Sanjay.
We need to give
yes,
it went in.
Yeah, I am lucky.
Okay,
Very
fine,
lucky.
fine.
આ કાઢ લે હજુ થોડું અંદર જવું પડશે.
We've had a new one for a long time and I still do that with my foot.
Okay. Sanjay?
Yes. Okay. Chalo.
Yeah, now let us check it with an injection. Everything is okay. Just a little bit of scout there.
Still
We have to
little
go
more,
in
yes,
little
yes.
more.
Giving a torque to Sir
Okay.
Rota wire is very difficult, but I think you have beautifully entered that PDA.
I am lucky, Tarun.
Yes, sir.
It's
But
Okay.
being a stainless steel wire, very difficult to torque.
now this is a coordination. Sanjay wire.
Ah,
પાછળ અંદર ગયો. How much I go in, Sanjay will pull it back. And now we increase our speed of going in. This coordination is so important. And we should be near now. Yeah. Okay?
okay. Still little, which,
જોઈ લો સંજય સ્કાઉટ
a little more.
અંદર ઓકે
Okay.
1.5 છે ને
1.5, yes.
why it looks like 1.25
No, 1.5.
Okay.
This is written.
yeah okay now dyna off and I will be just go સંજય આ સીધું રાખ.
I'm holding.
જોઈ લે
Well, it is inside recording. Push it. Okay.
આ થોડુંક ઢીલું કરવું પડશે લે ઓકે ફાઇન સ્કાઉટ જોઈ લેવું છે જોઈ લે વી ડોન્ટ હરી ના ધીસ ઇઝ ટુ
Perfect.
મચ ઇન
That
હે ને
is okay, પણ પાછું આવશે ને.
હા ચાલો આઈ એમ લૂઝનિંગ ઇટ એન્ડ યા to start with, also patient has a blood pressure in 180s, so I am not trying to reduce it anymore. We'll wait. Patient is stable. ECG is also stable. And one more pass and we will go distally.
Tejas, when you go distally, if you could for the fellows explain what you're doing, because distal rotor is a different skill.
Yeah.
How to advance the whole
Yeah.
system and press the brake off. at
That's
the back.
right.
Maybe you could
That
go
is
through
what
that.
I was asking. Sanjay has a brake in his hand. He is holding it. So, Rajiv, for a solo operator will not do. There are experts who are doing it. But these young guys, I will always say, you are doing complicated case. Even if you are not partners, you should have some, sort of a temporary partnerships for doing this type of complex case. Because 2 or 3 brains will always work better than one brain when some problem happens.
I 100% agree with that, Tejas. I mean, the things that we miss, even as experts, we miss the guide coming back and a loop of wire forming in the aorta. We miss arrhythmia. All of those things, I think a second operator is very, very helpful.
This is a very slow rotablation I am doing. I am trying to scrap the superficial calcium, and now we will go in, Sanjay. Chalo. Now just show the focus here and just see the movement, Sanjay is doing.
What was your RPM there?
150,000. 150,000. I think Japanese way of doing rota, professor, is a bit different, like 170, 180, or maybe 200,000 RPM, right?
Yeah. But each depend on
We are little scared in these arteries.
It is RCA.
Yeah.
Go.
Come.
Use Dynaglide?
Yeah, Dynaglide on. Rajiv, we are going ahead with Dynaglide. Scout, guide catheter. No, we have to still go in.
Yes.
And Sanjay is holding off the brake at the
Yes,
back, right?
he's holding the
maybe
brake.
show that. That's great.
हाँ वायर बराबर
वायर बराबर છે એડવાન્સ કરીએ છે પાછું થોડો
over है. Let me just simply go in with the regular speed.
Okay.
Or else wait. Wait. I have something in my mind.
You can start borrowing.
Huh?
નહીં થોડુંક જવું પડશે.
Line, it's a 1.5 bar, no problem.
વાયરને પુશ કરું છું. I have pushed wire little.
Okay.
Yes.
Let's
fine.
pull the back. Same dyna, and I have pushed it in because the artery is pretty big. I am sure that we are not hurting the intima. Scout.
Perfect.
Perfect.
We start.
So dyna off. And fluoro, we start. Yeah, this is tough. You can see. This is tough. So, this is, that is bradycardia. We will wait. Somebody should be there with adrenaline atrophy. Everything is fine. Just wait. But increase the speed. 160.
In ચાલુ માં જ વધારવી પડશે.
Wire. Okay, fine. Somebody keep an eye on.
It went in.
Yes.
See, there is rhythm disturbances, but it must be transient.
Just wait for some time. No problem. I think AV nodal branch is going from that area. That can also some embolic material.
I'm not sure if the panels can actually see the rhythm, but up until then it was just perfect sinus rhythm, and then some 2-to-1 AV block, very temporary for 4 or 5 beats.
Yes.
So it proves your point.
And I think a beautiful movement of wire as you were rotablating, because the hard and the soft part, that's the point that you want to avoid when you're rotablating.
Okay, fine. That is Brady. We'll wait. I think this is enough. This is one more pass. Okay, Sanjay feels that there should be one more pass. See, whenever my mind gets clouded, he's the one whom I ask. And then I don't think twice.
Just the Japanese position paper says that they go the final run at much lower speed, like 130, because of judder and a bigger sweep. Do you ever do that, or you stick with one speed?
No, I don't think. At least we have the same experience working like the same. So I will adhere to this technique, but it can be good because Japanese are doing so much of work. Okay, I think this is enough. Now, the important thing is just see the coordination, how we come out. Dyna off. Wait. That is Brady. We are fine.
Okay.
Dyna on.
Okay.
Dyna on.
Okay.
And now Sanjay will remove it. I will simply keep this in hand. Just camera here.
So again, there was a little bit more bradycardia there, but it was made up by all the extra heartbeats here in the room.
It will be, this rota has made at least our job easy for the distal lesion, about which I was worrying more rather.
Microcatheter.
Microcatheter. In fact, we can put another wire.
Okay.
Law. And let us inject and see, Sanjay.
Okay.
Let us inject and see. Because.
Okay. Fine.
It looks good.
Excellent demonstration, sir.
It looks good. Now we will put another wire, run through.
Or balloon trapping we can show.
Balloon trapping. Okay, Sanjay wants that we should show the young guys balloon trapping. Okay, we'll do that. Get us a balloon.
Microcatheter.
Tejas, even the proximal lesion looks different. I mean, it looks like that protrusion is less visible now.
That's right. That's right. Rajiv, we will now dilate and then again see OCT.
Balloon 2.5.
2.5 or maybe 3. Yeah, we can use the same balloon.
Yes.
Yeah. 3 by 15 and SIP trap neo. Balloon trapping, Sanjay, please explain.
Yes.
You know, the young guys in the audience, most of the senior guys know about this, but this technique is worth learning because it helps you in this whenever you are doing this type of exchanges.
Okay.
Sir, Tarun here. Would you like to do IVUS in the ostium of PD now, after burying?
I don't think. I will not, Tarun, really waste time doing that. Let me dilate and fix that.
Fix that.
And that will reduce my heartburns.
Fine, sir. Fine. Thank you.
Okay.
Fine.
Now we have removed the rota wire. Now
Run
this
through
micro catheter, yeah.
Run through. Yes,
Run through.
yes, same wire.
Same wire. And how Dr. Sanjay removes micro catheter, that he will like to show.
Because this is not
This is a long catheter. Catheter is longer than the wire.
Yes. This is not exchange PTC wire.
This is not an exchange wire.
So fluoro.
સામે ધીરે ધીરે એને લગાડી દો. 1 cc આપો ડિલજેમ. પેલું આપણે ઓફ લાઈવ હો.
So I am removing microcatheter. Where it is? बता दो. क्या है tip?
Tip. Where is the tip?
Okay. This
We
is
are there.
in the guiding catheter.
Yeah.
Okay. We cannot pull microcatheter like this because we
Yeah.
have the only this much length remains. So wire will come out.
Yes.
So what we will do, we will inflate balloon in the guiding catheter with any balloon about 2 millimeter in diameter.
Yeah.
And we will fix the wire, PTC wire, and then we will pull microcatheter.
Okay.
So it will remain stable.
Just show. Keep the camera focus here now. When Dr. Sanjay is keep going in. The balloon without anything is pushing
even
it.
not
Yeah.
PTC wire.
Not
is
even
also
a
not
coronary wire. Nothing. Hey.
Okay. I am pushing. Pulling back.
Yeah.
Rajiv, can you see the pressure there in the room?
No, we
okay.
can't see the hemodynamics.
Okay.
We're watching
I just wonder before we...
See, now our balloon is in the distal part of guiding catheter inside.
Sanjay, before you inflate the balloons,
Yes.
can we just get a camera on the
Pressure, yes. Okay. So
Yeah, we have given
now I am inflating balloon, so wire is fixed in the guiding catheter. Okay.
Yeah.
And now we can safely pull this microcatheter
Without any problem.
Without any losing excess.
Yes. Now he will deflate the balloon.
And pressure will reappear.
Yeah. Okay, fine.
I think one of the key safety things though is to make sure that you're bleeding back so there's no air has been
That's right. That's what actually I am doing. Lovely. Finish. Now let me go in with this balloon. Sorry. He will now, put the balloon on the wire.
It was a great demonstration for the young people. Tejas, Sanjay, you must show at some stage the demonstration for the old people, how you load the balloon on the wire with the syringe.
Yes.
Everybody
Yeah,
needs to see
just
that.
now. Focus the camera here.
Focus camera here.
Yeah, all those guys who have pressed biopia should know this.
Or even, it is very easy. It is a syringe.
Focus here.
Focus here. Okay. I am putting wire here, balloon here, and I'm just pushing.
And it goes in. This is the default thing in our lab. Every new fellow or whosoever comes and joins as a new cardiologist, we teach this.
It's amazing, Sanjay. That's your legacy. We're passing it on through many generations, that
Yes.
trick. So all around the world, everybody uses this now.
Okay.
Yes, this is in. Perfect.
So, I'm going up.
Huh? Barabar se go. Scene.
6,
8, 10.
8, 10.
Wait. We have to go up. I think we go high. This is a bad area.
10.
12.
Was this a semi-compliance or a
No,
non-compliant?
it's a non-compliant. NC track Neo. This is a new balloon from Abbott.
12.
Deflate.
I think it is dilated.
Yeah, this is okay. One thing I love to just give an injection here just to make sure that I have not perforated that region. Always just check it out. Okay, this looks good.
Wire little bit.
Wire is not in a good position. Okay. Now let us go to the proximal part.
Little back.
Yeah.
Yes, fine.
Yeah. Okay,
Fine.
go. 15. It may rupture. It won't. Okay, that's very good. 15, 17, 18.
18.
Deflate. Why papyrus has to be here, huh? Yeah, deflate.
I have deflated.
So I think it's unlikely you would have seen that if you had not done rotablator.
Rotablator, I was tempted to do mainly for the distal lesion, Malcolm, let me tell you. Now, Professor Akasaka, should we do an OCT run? Yes, we should. We are going very slow and step by step. I hope it is okay with the audience as well as the panel.
It's a perfect pacing because it's time for consideration, discussion, ask all these little tricks. It's really great pace. So please keep it the same pace.
And let me tell you, Rajiv, I am otherwise a very, very impatient doctor in the cath lab, and I really don't like to waste time. And that's the reason that, Aman, although he is my son, I have not trained him. He has been trained by Sanjay and assisted by Rajni for the training to Sanjay, because I like to shout if they don't do as per my protocol. That patience Sanjay has, fortunately. Now, yes, now he's scrubbing with me, but not anymore during his training time. I am interested mainly here in
distal wire.
Yeah. I will not go too distally. Let me tell you, I am going to evaluate only the proximal area, because distal, if at all I want to evaluate, I have to use IVUS, and that I leave it up to the audience.
Okay.
Wait. बराबर है?
हाँ.
जोई ले scout कर दे. Okay, good.
Fine.
चलो. This will come out very fast. I think we have done some good cracks on the nodule. For sure, the way the catheter moved. Yes. Yes.
Okay. Right. Okay. From here, right, we identify the branch here, acute marginal or some a little bit proximal branch, right? Okay.
Yes, there are
Right,
cracks.
yeah.
There are good cracks.
Yes.
Pulverization because of rota there.
Yeah. Right.
And the cracks
Cracks
because of the
here,
balloon.
right, yeah.
Yes. Yeah, good.
Yeah.
Very good.
Still some calcium, but
Yeah.
yeah.
Yeah, there are, I think, the
Right,
stent will
right.
expand for sure.
we can identify the branch here.
Yes.
So that is an epicardial site, might be, yeah, right? This is, yeah, myocardial site, yes. Some dissection, but
yeah, there's a big, there are cracks.
in the crack, right?
Yeah, 9 and 3 o'clock position, yes. Yeah.
And
I go,
here
I
is a
go.
very clear rota portion, right?
Yes.
Yeah, I think we can identify.
That is
some,
a,
right,
nodular calcium.
Yeah. And some dissection
Dissection.
after ballooning, right? It's okay, right? So, as I told you, this nodule is far from the
Yes.
wire. That is the reason why we cannot abrade any
Yes.
more, right? Okay, it's good. Yeah, yes. Proximal diameter should be around
It is around 3.2, I think.
3.2, right?
Yes.
Yes. Lumen diameter, right? Yes.
Yes. And the distal one is much bigger.
Yeah.
So, I will like to restrict the distal strut to protrude in that sort of a ectatic segment, maybe 1 or 2 millimeter, that is fine. But I will not go ahead with a 3.5 stent, for sure. I mean, our American friends may have a disagreement with this, but yeah, I will do that. Another thing, I can visualize the post-stent OCT run in this case, where you will not see completely circular areas and you will find significant malapposition in a very short segment of that nodule and oval region. But that is all right.
So, sir, on that thought, do you intend to combine IVL with post-rotablation?
It's a good question. I think IVL, in this case, I am not sure how much it is going to help. We leave it up to Professor Akasaka.
Yeah, IVL might be effective to the this very thick calcium, so the combination makes a little bit better to the severe calcified lesion. But there are some discussion, right, at the site of the nodular calcification back side. If there are a seat of calcium, if we have crack, we can dilate much more, right?
Yeah, that's what I feel. And you know, if you don't mind, if we don't do IVL and we see after the OCT run, it will be a good demonstration and I am sure that nothing will go wrong.
Any comment?
No, actually my only comment was I kept thinking this was a bigger vessel angiographically, but I realize now that you're on 15 centimeter field of view rather than the 20 or 22 centimeter that we often use in the United States. But the OCT recalibrated my mind.
Acha, now, regarding the distal lesion, what is your opinion? Will you like to see the IVUS? Okay. Yeah, it is possible. Get IVUS ready. And then we will stent and do the final runs. Perfect. ડૉક્ટર સાઇટો આવી ગયા છે ચા પીવડાય અને કેસ બતાવી દો એમને કેસ બતાવી દે સ્ટ્રેટેજી નક્કી કરે એલઈડીમાં કે એમાં જો પછી જરૂર લાગે તો કરી કાઢજો સ્ટેજમાં આવી બરાબર.
Tejas, while you're there, maybe you could just update us on the progress of the patients from yesterday. They did okay?
I tell you, in the morning, I took a proper round. Every single patient is fine, including the last case done by Dr. Shigeru Saito, where there were a lot of heartburns in the audience as well as everybody over here. And all those cases are doing perfect. You know, God has been very kind to us. And I think they were all cases in which we could have landed up with some complication or other complication somehow. But I think they have done, and we are discharging all of them today.
That's just fantastic. They were so complex cases. It's really great tribute to your whole team's skill there, Tejas. Thank you for telling us.
Thank you. We have an investigator-oriented protocol here at Apex where we are doing IVUS and OCT in the same lesion, you know, eye opus, and we have collected at least such 50 images. I think that can be a good material for the young generation to learn, and someday I will like to discuss that.
Yeah, it'll be very interesting because Octavius trial did not show any difference, but I think that was all Caucasian population. In Indians, maybe we'll come out with some different data sets.
That's right. Yeah.
Yes, yes. Should have.
So we are preparing IVUS. It will take 1 minute, and this is simply to know and learn about the distal lesion where we have, I think, cracked a calcific nodule, proper calcific nodule. So how the calcific nodule or calcium looks on IVUS and how we can interpret it, I think we will like to hear from Dr. Akasaka.
Maybe Tejas, a little bit, since you have a second, your opinion on what we just talked about a few seconds ago. After you do atherectomy, when do you think it would be a good idea to do IVL in addition?
It's a great question. In this case, Khaled, in this case, you saw 3 nodules in the same lesion, and none of the nodule was complete loaded, opaque calcium. They had differential calcium thickness, and we have seen cracks in every nodule. So here it is okay. But if I see a big nodule and Rota has not worked without any cracks, because Rota in IVL will show some pulverizations at the border. The balloon, the non-compliant balloon will show cracks, the big cracks, like blocks. And IVL will simply will act like a crusader and do lot of breakage over there. Here, I think it is a good idea. Non-compliant balloon, we have to dilate afterwards, but we should be able to give a good MSA for sure.
Yeah, no, I agree with you. I think we saw enough cracks that we think this lesion should respond. So I agree with you.
In India, we have to think about, patient's pocket. So we have to carefully select our. Barabar hai?
Julia, let's little more.
Huh?
Wire. Wire we have to. Yes.
Yeah. No. Okay.
Okay. Little more.
Okay. I think so. Wire. Chalo, let us start.
Yep.
Professor, your comment.
This is an PDA, right? Yeah. Almost normal or some fibrous plug can be seen, right? And here is a trifurcation, right? Yeah.
Nodule.
Nodule. Yeah. And then the distal, just proximal to the bifurcation, still have some protrusion and nearly 180-degree calcium, and then become very normal, right?
So my question to you is, Professor, there are so many learners of IVUS here. With OCT, we have a very objective documentation of the thickness of the calcium and about, whether it is a differential calcium thickness or whatever, and the thickness, length, as well as breadth and everything. How do you decide the thickness of the calcium and about the calcium spread looking at the IVUS vis-a-vis OCT.
Yeah, right. The IBUS, generally speaking, there are lots of shadow from the calcium.
Multiple
So
breaks.
correctly speaking, it might be very difficult to measure correctly. But if the calcium is very thick, we can
It's a big
identify some another shadow from the surface calcium, right? So it, if you find some such findings, yes, please stop. Yeah, we can speculate the very thick calcium, right?
Yes. Now I am removing this, and without wasting time, I am going to stent it. So proximal, I know it is 3. Can you tell me the length, Professor, for the proximal lesion? Distal, I know.
Proximal is nearly 12, right?
12.
Normal to normal, right?
Normal to normal is 12.
Yeah.
So we can take 15, even the proximal area is good. It is RCA, and when you are working, through the radial approach in RCA, sometimes patients take a deep breath and the things, the stent moves and deployed proximally. To avoid that, I will always love to take a little longer length, looking at, when I have done OCT, I will try to go and find some proximal or distal good areas to deploy.
Distal.
For distal, again, can you tell me from, the distal artery diameter looking at 6.45.
Yeah.
So it is about 2.7?
2.75, yes.
2.75.
Right.
Here we can take maybe 3 millimeter.
We have dilated.
Yes.
And we will dilate proximally slightly bigger.
Yes.
So 2.75.
We have
Yeah,
dilated
proximal
with 3.
is
3. So we'll take a 3 millimeter stent distally, and maybe give me 3 by 15, and these are calcified lesions, so my preference will be Zions platform, preferably, or onyx, but here I'll take Zions. Zions alpine 3 by 15.
the length is 15, right?
15.
Yeah.
Tejas sir, on an IVUS we can see the beautiful cracks in the calcium. It has been seen that when we are, evaluating the proximal part, there are multiple cracks and there are differential cracks.
Yes.
That has been seen. And the protruding nodules also get lot of debulking because of the rotablation.
Yeah,
Yes.
but see, that is where, sometimes I need to learn it. I need to learn it, how you exactly evaluate post-rotablator or post-IVL, interpretation.
So when we
I am
see,
not very good at it.
so when we see reverberation after rotablation, that suggests that we have done a multiple cracks.
Yes.
And that is the
Scout.
reason I think we can see
Little more.
Yeah.
Little more.
the area behind the calcium. Otherwise,
Inject.
it is a low acoustic area,
Okay.
and
Yes.
you will not be able to see because the sound waves, they are not going to pierce behind the calcium. So that part will look like a eccolucent area.
Reflect. Yes.
Fine.
You think we can go here? No, negative residual distally.
Even proximal, it's
Not good. So go here at around 15,
okay.
and then that should be okay. 15, this becomes what? 15, this becomes 3.21. Record and deflate. What do you think about the expansion, apposition, and all these things? Out. Inject and see, and then
Looks good.
lovely. And you saw all the branches are very well protected. And here, all this crowding of, particularly crowding of the wires in heavily calcified segment, sometimes can be a problem for the operator. So I like to be very, very minimalistic inside the coronary. And now proximal also we decided to take a 3 millimeter stent, right? 3
Yes.
by 15. Get
Yes.
me Zions alpine. Here if I find Malcolm a lot of malapposition segment, little longer segment distally, then I will expand it with maybe short 4 millimeter balloon, not otherwise, which will probably 99% it will not be required.
You think this would be a little longer than 15, Tejas?
15 is perfect, Khaled, because
Seems longer than the distal lesion.
we are dilating, we are not going till normal to normal segment. We are trusting here the OCT finding and deciding the length, which is around 12, but at 15 also it is good. So
3 by?
Because if I am going proximally, I have to take a 4 millimeter, and there are 3 nodules which are partly broken. That is a concern, matter of concern for me, for the perforation in that region.
315.
Yeah.
Well, we were measuring it up here as well. Looks like 15. Can you see the OCT in the auditorium?
Yes. Yeah. Yes. Chalo, lay lo stent. Dr. Saito.
Saka said this is the perfect size.
OCT run.
Lesu na. OCT lesu bas.
Yeah, I think still there are lots of discussion about the calcified nodule, right? If we put a stent and if there are lots of protrusion, there are high risk of the restenosis. Therefore, in Japan, one study is going on using a drug-coated balloon, right, to avoid the restenosis.
Yes.
We are not sure the final result, but leave nothing behind might be the one of the option at the site of the calcified nodule.
Barabar cha.
Smooth
Move thigh, it's moving, yeah. So we have to be very quick. Ek minute chal, check it. Go. No. Payal.
Yes.
Payal, go. Quick. Quick. 10, 12, 14, 15, 18. Like for it is over. Wait. This is that Nipro device.
18.
Huh?
18.
Lovely. Deflate.
Yeah, so because we are occluding.
Yeah, bradycardia, no problem. Wait for some time. Sometimes what happens is guide catheter inadvertently goes in and SA nodal branch is occluded. That can give rise to SA nodal ischemia. Okay.
Wow. It's fine.
It looks good.
Distal
Wire.
Full
Okay, fine. Now we will do OCT of the proximal part and then we conclude the case. Distal I don't want to indulge anymore. This looks good. OCT. It's important to see the OCT in that region. Why give 1 cc diltiazem? There is a good chance that she has renal. Okay, it has gone distally. Yeah. Just check it. Sanjay says that we have a U distally, and if we can make it, let us try it out. I am not sure.
So Tejas, let me ask you, so going into this with OCT now, do you have in your mind criteria that will make you post-dilate?
I will just see and then I will give my comment, because sometimes it may be little bit different as per the criteria decided in OCT. I will always think of the safety of the patient, and I will not like to make it picture perfect at times, because in this patient if you create a big perforation, fine, we have papyrus available in the lab. Unnecessarily we are doing a lot of disservice to the patient. So I will let me see, and I will give you some sound reason for doing it or not doing it. Okay.
Okay, we have one there. So 2 suits, huh?
Yeah.
Okay.
Go quickly. Chal bhai.
We'll take 2 shoots.
2 shoots, and go on high definition mode.
Okay.
Beautiful.
Crystal is okay.
Quickly.
पाछू ले ली तू थोड़ा. Fine.
It's going in and stop karo. Bas thai gyo.
बस OCT image.
Yeah, OCT image.
Yeah, distal position is very good, right?
Perfect.
Perfect. No dissection, right?
Yeah.
Yeah. Here is an distal end,
Yeah.
right? A position is okay, right?
Perfect.
Yeah. The size is nearly 2.6, right? And then, yeah, the symmetricity is okay, right? And then here is some protrusion as, yeah. And here is
Bifurcation.
Yeah, bifurcation.
Bifurcation, right? The proximal site is here.
I think as a clinician, it is extremely acceptable to me.
Right.
It's all
Proximal edge is okay.
Perfect.
A position is okay.
perfect. And the area, landing area is also very healthy.
Yeah, right.
Yeah.
चलो. Wait.
Okay. पाछो.
हाँ ले लो थोड़ा पाछू. Okay.
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 थोड़ा अंदर.
थोड़ा अंदर. Okay. I just.
Okay. Chalo, let's do this view. It's a great image. Perfect. Rajiv, yesterday, the first case, we were struggling with OCT. And many of the people sitting in the audience must be thinking that they are struggling. But it happens once in a while. You saw every time there is zero default afterwards.
Yeah, no, this is very slick watching you do this. I mean, really quick, easy, with amazing images.
Look at this.
Here is the distal portion.
Yeah.
Some, yeah.
How many struts are there?
1, 2, 3, 4 incomplete position because
And
of the
how long is the area coming protruding in the
here
region?
is
We expected this, Tejas, right? I mean, this was
Yeah,
completely expected.
absolutely, absolutely.
only 3 millimeter, right? You can identify the incomplete position
Yes.
by red color, right?
Yes.
That's on 3 millimeter from the distal edge.
And where is the extremely objectionable malapposition?
It's okay.
It's very small area of,
Right.
area more than 400 mics, right? Malapposition
Yes,
more
yes,
than
yes.
400
Yeah.
mics.
It might be very difficult to get a complete
Absolutely,
position
absolutely. So I think this, to us, this is a very, very, very acceptable result. Extremely acceptable result. Any comment?
I think it's a fantastic result. I honestly do. And I think one lesson is we have to remember malapposition has never been correlated with stent thrombosis. The only thing that correlates with stent thrombosis is under expansion.
Yes.
We mustn't worry so much, obsess about the red color, the malapposition. It's expansion that matters.
Malapposition for more than 3 millimeter length and a bigger, in that case, and if you have more than 400 microns, of malapposition, there is some matter to worry, not otherwise. And very proximal region like ostial LAD or something, or left main ostium, where at times, for second intervention, your wire entry can be a little bit challenging. So there you have to be very careful, not otherwise. One or more shoot, and then we will switch over to one most interesting case Dr. Shigeru Saito is going to do. Scrub થઈ ગયા છે ને? જોઈ લો ફટાફટ સ્ક્રબ કરી દો. ચલો. Any comment? Go to LAO. LAD and circ, we are going to stage it.
I think this looks fantastic.
Thank you very much.
Excellent demonstration, sir.
Thank you. Thank you.